right in the center of the circular villus. Okay? It's very well protected in the sella turcica. Okay? The other exocrine glands have ductwork that secretes their products like into the digestive system or the salivary glands, which into the mouth, but they have a tube that carries their stuff. I also told you that we have dual gland, or both exocrine and endocrine. So remember, the liver is an example of one, the pancreas is an example of one, so they can be both. So I listed the major endocrine glands here. Notice it says the hypothalamus, which monitors a lot of your hormone levels and has a lot of release type hormones. Pituitary gland, the thyroid, the parathyroid. So all of these glands that I've listed here are the major ones. I also put down here that the pituitary gland produces trophic hormones. Okay? And notice that this is a very key definition, that trophic hormones act as intermediates by stimulating hormone production in other organs. Okay? That's the definition of a trophic hormone. So what I've listed here are the trophic hormones that are secreted by the pituitary gland. So, most of the hormones are regulated. Oops. Oh, lost it. Okay, most of the hormones are regulated by negative feedback. So keep in mind that when the hormone levels go down, these trophic hormones will stimulate them to produce more of what they're supposed to release. And once the levels get up to normal, it turns off the mechanism. Okay? So that's what TSH is basically designed for. Now, I think we talked a little bit about the types of complaints patients with endocrine problems would have. And, you know, unfortunately, these are probably the symptoms that most of you have right now, correct? Fatigue and weakness, weight changes, well, the sexual maturation and function, mental status changes, and polyuria. What is polyuria? Yeah, going to the bathroom a lot. What's polydipsia? Okay, excessive thirst. Okay. Now, the easy part about endocrine problems is either they're overproducing the hormone, underproducing the hormone, or they have a tumor. So this is the real simple thing about diagnosing endocrine problems. The tumor is benign or malignant. Okay, and that's kind of where we're here to find out. The next few pages, I'm going to let you guys just kind of go through this. This was mostly from the handout, but the hormones of the anterior pituitary and what they regulate. I think most of you remember this from your anatomy and physiology, so I'm not going to spend too much time on that. But you notice that that quiz that I gave dealt with this a lot. Okay? You should know what these different hormones do, because especially with the pituitary gland, if you haven't done it now, you'll be doing octreoscan imaging at some point. Okay? And a lot of times when patients have pituitary adenomas or problems with their pituitary, that's what we're doing here. Okay? So, as you can tell, you have the answer key to that, so it tells you what hormone does which. Okay? The other ones that I wanted to sort of just touch on here is, remember with the posterior pituitary, one of the very important hormones that we'll be dealing with later is the antidiuretic hormone. Okay, so when patients are dehydrated and you have an abnormal renal function, this is probably the culprit. You have antidiuretic hormone that prevents the kidneys from releasing water. So basically it looks like you have obstructed kidneys. We talked about the hypothalamus, the two important hormones from the hypothalamus, the TRH and somatostatin. Okay? And Remember, somatostatin is the one that we've labeled. It's a peptide. We label it with I1 with 111 Indian, so we can image somatostatin tumors. But it's also used as treatment. So you have to be very careful when you're doing indium octreotide scans, because the patient may be on on somatostatin as a treatment. Okay, so that's just an FYI. It's one of the medications you need to make sure you ask the patient. If you haven't done so, you may want to take a look in Shackett's book. Are you looking in Shackett's book right now, under OctreoScan? Does it say, ask if the patient's on somatostatin therapy? Let me just borrow that for a minute.
It says suspend medications for 72 hours.
Okay. On chapter 34, page 182 of your Shackett book, okay. Now remember, because it's a peptide, it's going to be treated, it's going to be chemically treated different. It's going to be incorporated into the somatostatin. So, okay, so the indications, and this is a good way to help you study for the endocrine section, is take a look in there and see detection and localization of somatostatin receptors on primary metastatic neuroendocrine tumors. So this tells you all the tumors that you could be dealing with. Lung cancers, medullary thyroid cancer, pheochromocytomas. Remember, incidentalomas. Okay. The patient preparation. So make sure that patients that are on octreotide therapy should suspend their medication 72 hours before injection. Thank you.
So indium 111 DTPA and octreotide are two different things?
No, pentriotide is it is actually DTPA pentriotide. But they call it OctreoScan. That's the trade name of it. Okay, so anyway, like I said, I don't want to, you guys can take a look through that. The thyroid, which we're going to be spending some time with this morning, or this afternoon. Okay, we talked a little bit about it before. We're actually going to be spending time with the parathyroids and the thyroid after we go through this sort of a quick summary of the endocrine system. But remember that basically thyroxine and triiodothyronine, those are metabolic agents for glucose metabolism in cells. If we don't have that, the cell can't burn glucose. Okay? If it doesn't have insulin, the insulin can't get into the cell to be metabolized. Calcitonin, remember that it stimulates osteoblastic cells in the bone, so it takes calcium and stores it. Okay? In fact, they were using that as a treatment for osteoporosis, but apparently it didn't work. So, then the next thing we have the parathyroids. So remember, this is the one that releases parathormone, which causes calcium to be released off of the bone by stimulating the osteoclasts. So we have two cells in the bone that we're concerned with, both influenced by thyroid and parathyroid hormones. The adrenal cortex. Okay, we talked a little about these guys. So we have two groups of hormones. Okay, these are the anti-inflammatory hormones here, the hydrocortisone and corticosteroids. And then this one over here, the sodium and potassium, aldosterone. And then also, because remember the cortex is divided into these three levels here. The androgens, these are the steroids that people talk about selling illegally. The ones that are produced in the adrenal cortex of the adrenal gland. And then the other ones that we're concerned with, the catecholamines, So this is why MIBG is real good for the adrenal medulla. Okay. The NP59 for the cortex, and the MIBG for the adrenal medulla. The pancreas, you know, we have a lot of somatostatin receptors down here. That's why I say you have insulinomas and ganglionomas and things like that. But again, the liver stores sugars, and the alpha cells of the pancreas release it. So that's why we get glucagon to cause sugar to be released. And again, this is a real good antispasmodic. If you have patients that are suffering from, well, just spasms of the colon or intestinal things. And then remember we talked about insulin, where it has to be available for the sugar to enter into the cell, otherwise the sugar just stays in the blood. These two are very, very important, especially for doing FDG scanning, correct? We have to monitor the glucose. If the glucose is too high, then typically we'll give, I want to say about 1 or 2 units of insulin, wait an hour, and then do another blood test. But insulin can also affect the biodistribution. Normally, sometimes when we give insulin, we see the glucose going to the heart. Normally, that isn't the heart's first choice of energy. You know, we'd rather have fatty acids, but sometimes you got to eat what you got to eat, right? It's one of those no thank you portions when you go to Aunt Martha's and she serves you liver. I hope nobody here likes liver. Okay. But anyway, so be aware of the pancreas. We do image that with the octreoscan scan. Ovaries, placenta, testes. Not really too much that we image with that. But moving along down here, we talked about the thymus gland last week. Remember that the thymus gland does pick up FDG. We do see tumors there called thyomas. But remember that this is the source of your T cells. So the killer cells, the helper cells, the suppressor cells, all either hang out or are produced in the thymus gland. Normally it's very large on infants and children, but then it disappears and you really don't see it much after that. But it produces thymosin, which for your immune system. Okay.
And it was on your past test, that question.
Yeah.
So
And then but like I said, you can see where I get my questions from. So, the melatonin, for many, many years we didn't know where's the pineal gland anyway? Okay, yeah, it's right, almost right in the middle of your, it's right behind the pituitary gland by the corpus callosum. They didn't know what it did. So now we know that, or this is what we think it does. So when you can't sleep at night, bang yourself on the head. And if the subdural hematoma doesn't put you to sleep, then hopefully you'll stimulate your pineal gland. Okay? I've listed some of the diseases here that you might hear about. So if you have patients with these different conditions, you know, I don't know if you've ever heard of Addison's disease. Have you heard of any of these things before? Yeah. Okay, Cushing's syndrome. Cushing's syndrome is where you get that sort of a moon face and yeah, hump in your back. And then the gigantism, you're either too tall or too short. Now, if the growth plates have already fused, then you get acromegaly, where yeah, you get bone deposits on the existing bone that you have, and you wind up looking like that guy that played Lurch on the Addams Family, or who's that? The giant one. You know, the guy Andre the Giant. Yeah, he died from acromegaly as a result of that. A lot of times it's a pituitary adenoma or pituitary tumor. And then the antidiuretic hormone, if you have deficiency, then you're peeing all the time. So basically you could drink a gallon of water and you're going to lose a gallon of water almost immediately. So these people don't usually make it. So a lot of times it happens with trauma to the pituitary gland. So thyroid gland, either underactive, you get cretinism or hypothyroidism. So we'll talk a little bit about that. There are areas in like the Andes Mountains where it's hereditary. There's no iodine in the soil, so everybody up there is a cretin. They're all sort of mentally retarded and, you know, sort of slow and small and things like that. Yeah. And there's areas called the goiter belt. I don't know if you've heard of that. Even here in the United States, like up around Minnesota and Louisiana, believe it or not. One of the things that they...
To this day, we call the iodized food?
No, not now, but that's why they put iodine in salt. They started creating iodized salt, so if you look at Morton's iodized salt, it was designed to prevent this. And usually, if anyone's been pregnant lately, one of the things that they check is your thyroid hormone levels of the infant. So, if you guys have kids, they'll check that.
And they'll check for like mental information.
Yeah, well, what they'll do is they'll check for like, trisomy, the Down syndrome. Yeah, trisomy 23. And then they also check for thyroid hormone levels because they don't want the baby to have cretinism. And that's why also if somebody's pregnant, we don't treat them because the iodine will cross the placenta, and I think it's about the 23rd day or the 23rd week or something, the thyroid is actually up and running pretty well, so you don't want to kill it. But I just wanted you to make sure that you were aware of these different diseases that we have. Okay. So we're going to take a look at some of these things here. Now, pituitary gland, remember it's a term adenoma, it's usually a benign tumor. Can it kill you? Yes. But normally it will take a very long time for it to do that. But we do see pituitary adenomas all the time. We do see thyroid adenomas. Okay. Same thing. Remember, the medullary cancers are not very common. They're only about 10%. The undifferentiated are about 5%. And then the papillary follicular are the most common. Then the parathyroids, and again, this is kind of an interesting thing here. There's different statistics on this. Most of the ones that we look for when we do a parathyroid scan are the adenomas. Those are the ones that pick it up very well. The hyperplasia, again, just excessive tissue, or you may have parathyroids growing outside of, where should you normally find your parathyroids? Yeah, they should be behind the thyroid gland. You normally have 4 of them. You have 2 in the superior area and 2 in the inferior area. So, but you can find them almost anywhere. Yeah, not even, they're smaller than that. They're like about the size of the green chlorophyll things on chiclets, gum, or they're not very big. But anyway, so that's a common tumor that we see, the adenomas, thank goodness for us. And then the same thing here, the tumors of the adrenal glands. We do get some pretty nasty cancers that originate from there, and unfortunately a lot of these people die from, well, if it's a pheochromocytoma, they typically die from either the heart going into congestive failure or just the catecholamines in there. What else? The pancreas we'll talk about those a little bit later. But let's get down here to the thyroid gland. We already talked a little bit about the anatomy last week. So, just as a quick review, okay, now this is a fairly typical thyroid. So do you remember, what are these? What's this over here?
Right lateral lobe.
Okay, so well, probably just they call it the right lobe. And then what's this? Okay, and then what's this?
Left lobe,
Left lobe. And where is this located at?
right in your.
Yeah, remember this, that big lump that you have there is called the thyroid cartilage. So that might be a hint. So it's normally about the 5th cervical vertebra, around the 5th cervical vertebra. I wanted to show you a couple of different variations of thyroid. Okay, so here again is the right and left lobe of isthmus. Okay, remember what this is called here. What is that called?
What's that?
That extension.
Pyramidal lobe.
Okay, yeah, that's a pyramidal lobe. I've got actually a couple of examples of them here. I'm trying to, oh, here's a better one here. Okay. So, whenever you see an extension of tissue going up, that's a pyramidal lobe. What I also wanted to have you take a look at here. Now, when you take a thyroid uptake and scan, remember you're going to be taking a measurement usually at 2 or 4 hours after the pill, and 24 hours. Okay, it's always a good idea to make sure you get both. Now, I'm not really sure why or how they did a thyroid uptake with protectanate. I think somebody has the wrong radiopharmaceutical there. But, do you all know what your normal uptake ranges are? What's your 2 to 4 hour uptake range? Okay, yeah, usually it's about, usually maybe 10 to 20% in most places. Now, the real easy thing is this, the 24 hours should always be double that. Okay? So if you have 10% on your 2 or 4 hour, then you should have 20% on your 24 hour. Okay? So this one looks pretty normal. What do you think about this guy here with an 86% uptake? Huh?
Hyperthyroidism?
Okay. Yeah. The reason why it's important to have the image is because you see that it looks like the whole thyroid is involved, and that means that it's Graves' disease. Okay? Because sometimes you just get a part of the thyroid. Okay. Now, this was a patient who, this is overactive. This is a thyroid nodule that's overactive, and basically it's produced so much hormone, it's turned off the other side. And it's turned off these normal tissues here. Okay? So, usually it's called plumber's disease when you have a single nodule that does that. And so in this case here, you know, one of the things that they may do is a stimulation test. Give some TSH, give some more iodine, and see if they can turn on and see how much tissue is actually here. Because what we can do is kill this tissue. Typically with plumber's disease, we get a little bit higher dose than we would normally do for a Graves' disease patient. Graves' disease, we would probably give 8 millicuries at the most. And with Plummer's disease, you could probably get up to 25 millicuries of I-131. Okay. One of the things I wanted to point out here too, that, hey, it's not real obvious on this, but what positions or projections should you take when you do a thyroid?
AP, LAO, and RAO.
Okay, anterior and both obliques, right?
Yes.
And you guys put markers on yours too?
Suprasternal notch.
Okay, well, here's an example of why you need to do these. Okay, on the anterior view, you can kind of say, well, maybe there's something here. Which view do you think would best demonstrate what I think might be a nodule here? Yeah, you notice on the RAO you can see that there's a warm nodule here. And we classify them as hot, warm, or cold. Hot, we're usually concerned about the Plummer's disease. Warm or cold, we're concerned about cold nodules. And cold nodules are normally more suspicious for thyroid cancer. Even though thyroid cancer is not a real common one, most of these things turn out to be like thyroid adenomas. Okay, like, we just give you an example here. Okay, here's a real good one here, okay. This turned out to be just a colloid-filled cyst. Okay. One of the things that's interesting about these, if you notice the margins of the cold nodule, they're typically very smooth if they're an adenoma. If they're really sort of not real regular, yeah, patchy like that, then it's normally more suspicious for thyroid cancer. But on this one here, I don't know, this was actually done at my hospital, but I didn't do it because normally we write the uptakes down on the scans. And this is an analog image, so this was done before the computers. So most of the time you're going to see something that looks like this. One of the things I don't like about some of these computer formats is that they're so small you can barely see them. But this is a fairly normal thyroid, and you notice that on this case they have the anterior. Here's the anterior with the marker at the suprasternal notch. It's actually not the suprasternal notch anymore, is it? Oh, it's the jugular notch. It's right. Okay. So what some people do, they'll mark the suprasternal or the jugular notch, the thyroid cartilage, and sometimes they'll mark the chin. Okay, those would be most of the time that they would mark those. If you have a cold nodule that's palpable, sometimes the doctor will put the source on top of that to see whether the nodule that they're palpating is the cold nodule. Okay, you guys done that before? I always strongly suggest that you have every thyroid patient palpated by the doctor. Okay? Let's get some light underneath here. Let this thing kind of. Okay, so don't let that patient go without being palpated. Okay. And so normally when you do the palpation, you should have a glass of water so the patient can swallow, because that will help the doctor determine if the nodule is fixed or movable. A nodule that moves up and down with the thyroid is less suspicious of cancer than one that's feels like it's attached. If it's a hard nodule, that's usually more suspicious than a soft nodule. Okay. Let's see what else we have here that has to do with thyroids. Okay, but anyway, so some of the things that, okay, that you need to be aware of is that, okay, what the thyroid gland weighs, that's a normal question, 25 to 30 grams. And one of the things that I sent to you is a bonus homework assignment. But it's on the thyroid gland. It's the directed reading assignment from the ASRT. Have you seen that one yet? Okay. This is an article that was in the American or the Radiologic Technology book, but it had a really good explanation of some of the different thyroid diseases that we deal with. So, for example, if you can understand now why we get these thyroid adenomas, because you get these fluid-filled cysts of colloid. The follicular and the parafollicular cells surround them. The follicular cells produce the thyroid hormone and then release it into the colloid where it attaches. If you remember last week, we talked a little bit about the stages of how you make thyroid hormone. So remember, what is the first stage?
Iodized salt brings it in.
Okay, and we call that trapping. So any negative ion will be taken in by these follicular cells. What's the next phase?
Iodide is oxidized back to iodine.
Okay, well, yeah, basically, remember that iodine has a negative ion. It reacts with peroxidase. It's changed to a positive ion, and then it can be attached to the colloid. Okay? So what is it called, or what is the next phase where we attach it to the monoiodotyrosine or the diiodotyrosine?
Organification.
Okay, organification. Okay, and then the MIT and the DIT are then joined together, and what's that called?
Triiodotyrosine.
Well, we have a term for the process.
Coupling.
It's called coupling. The coupling is important because the anti-thyroid hormone drugs that we give the patient blocks the coupling. Okay, so propylthiouracil or methimazole, both of those block coupling. Okay, but these are the cells that turn cancerous too. Okay, so we have coupling. After it's coupled, it's stored in the follicle until it's needed. Enzymes break down the follicle and release it into the bloodstream. Remember that T4 is the highest percentage of hormone manufactured by the thyroid, but T3 is the metabolically active form. So the body cells will break down the T4 into T3 so that it can be utilized. Okay. The thyroid hormone is normally bound to globulin. However, there is a small percentage of it that gets taken off of the globulin prior to it being metabolized by the cell. So what they call the free T4, the free thyroxine index. Okay, and back pages I've got some stuff there. In between the cells here, you see these little things here. Those are the parafollicular cells. Those are the ones that secrete calcitonin. Those are the ones that have medullary cancer. Okay, so that's your medullary cancer cells. I'm not going to ask you about the action of the thyroid hormone because I've given you, this is the sort of physiologic thing that you need to know, but we're not going to worry about that, okay? I won't test you on this, but this is how you get energy out of thyroxine and triiodothyronine, okay, in the Krebs cycle. Okay, so if you guys, you know, we don't want to do that. But here's one of the problems, okay? The reason I threw this in here is because one of the diagnostic tests that we do on patients is, as we're evaluating them, we have them put their hands out. And in a short period of time, they'll start shaking. Okay, they'll have a tremor. The reason they have that is because in high concentrations, thyroid hormone blocks ATP conversion. So what happens, the muscle is unable to manufacture or turn ADP back into ATP, and it becomes fatigued very quickly. Now, the nice thing about hyperthyroidism is you really look good. You lose a lot of weight, you've got beautiful skin and hair. The only problem is your eyes start bulging out, your heart's beating like 1,000 beats per minute, you feel hot all the time, and you'll die. Your heart will basically just, yeah, but you'll be good, man. You'll be the best corpse at Forest Lawn, okay?
What's a life like that?
I mean, and that's it. I mean, looks are everything, right? If you're going to go out, you go out in style. Okay. And then the calcitonin, well, we already talked about that. But that's why I put this in here. In high concentrations, the hormone blocks synthesis of ATP, speeds up exhaustion, so they get tremor. Okay. The calcitonin, on the other hand, osteoblastic activity, increased calcium absorption in the gut. So it retains calcium in your body. Okay, now let's move on down here a little bit further. Okay, the thyroid hormone production, this is where it becomes very important to us. We've already talked a little bit about the trapping, organification, and things like that. But normally the thyroid only needs about 150 micrograms a day. And that's why any exogenous sources of iodine can very detrimentally affect our uptake in scan. So there's all sorts of things like cough syrup and medication and vitamins and everything that can affect it. One of the things that you should be aware of with iodine metabolism, notice it says 100% takes place in the gut, about 30% goes to the thyroid, 60% of it gets filtered out by the kidneys, and the 10% stays in circulation. So remember those ratios on a normal thyroid, okay? That's why the uptake is important. So, and then the thyroid hormone regulation, we talked about that too. It's monitored in the hypothalamus. TRH is released when the thyroid hormone gets low, and that causes the anterior pituitary to then release TSH. Okay? Because that's one of the things that we check. And sometimes you may check it by imaging the patient. Sometimes you may just do a blood test. We have isolated TRH. We have isolated TSH. So when there's a problem with this regulating mechanism, that's why you guys may be doing suppression tests, stimulation tests. The organification one, that's not really related to the regulation mechanism, but again, if we're trying to figure out if the patient has primary problems with the thyroid gland or secondary or tertiary. So remember, primary is the gland itself, secondary is the what? Okay, pituitary, and then tertiary is the hypothalamus. There's a lot of, I would say that I've done quite a few women who had just delivered babies, and because of a decrease in blood, or they lost a lot of blood during the delivery, it affected the pituitary. since it's right up there in the circle of Willis. I've listed some indications for doing that. I think probably I like Shackett's book better for the indications and contraindications. But some of the stuff that we're going to be looking at are, well, the radioactive iodine uptake is basically just to get an idea of how well the gland is, metabolizing iodine. And as it says, we can also do organification defects and things like that and see if we can determine if it's primary, secondary, or tertiary thyroid problems. And again, some of the tests that you may be doing is administering TRH and then monitoring the TSH levels of the patient. Does that make sense? So if those tests have been done, you need to include those in your information to the physician. Okay. So if they have high TSH or high TRH levels, those would be very important. Okay. So this is a list of some of the history questions. Changes in their weight, that's usually the big one. If they've gained a lot of weight, that's usually hyper or hypo.
Hypo.
Okay, hypo. And weight loss is usually hyper. Okay. And then the big thing is, okay, what are you taking that may cause problems?
Stress.
Okay, notice I put down here. If the patient lives in an area or has an iodine deficiency, when you give them iodine, they will take this stuff up like you wouldn't believe. In fact, there's a pathologic condition that is mentioned in our book. Yeah. Anytime you deprive...
So that grade sort of the term where it's really high at the 4 hours.
It's, it's something that's a different name for it. It's like Jen-Bard syndrome or something like that.
Joe based that?
Yeah. Keep that in mind, because when you ask the patient about the problem, page 86, right?
I believe.
Joe dazed out. What happens is you starve the gland, and then as soon as it has an opportunity, it's going to grab all the iodine it can. And the same thing is with this rebound effect. If the patient has been taking thyroid hormones or antithyroid drugs, you're preventing the thyroid from utilizing the iodine. So as soon as you stop, it goes crazy and grabs as much as it can. That's also the best time to treat the thyroid. If you really want to kill it, is when it's on that rebound. The subacute thyroiditis, there's a really good picture in our textbook. Sometimes you can have a patient that has a high uptake, or they appear like they're hyperthyroid, but actually what it is, they've got thyroiditis. So this is on page 86. The thyroid has been injured, and what thyroid cells are left are releasing T3.
What kind of injury would cause?
Infection, trauma to the neck, surgery, things like that.
For respiratory infection, like that?
Yeah. Yeah, colds, flus, sore throats. Anytime somebody says that they have a sore throat, it's a possibility. So subacute thyroiditis, like that patient. Pregnancy. Now, what's a high data form mole? Has anyone heard of that before?
Mole in pregnancy when HCG is super high.
Yeah. This is where it's almost like an incomplete fetus in the uterus. So it's like, a baby was starting to develop, and these are they're like balls of tissue. They have hair and teeth and eyes and thyroids, and
We've had a couple in the lab where we had like super high HCGs,
Yeah.
like way higher than they should be, in
Yeah.
millions.
So that's one thing. And in this particular case here, you would actually be looking in the pelvis for ectopic tissue. And then choriocarcinoma, that's, what's choriocarcinoma?
Isn't it kind of the same thing as that, but it spreads beyond the uterus?
Yeah, this is like an umbilical tumor, umbilical cord tumor. And remember, the umbilical cord releases hormones too. So, and then the other thing that we have over here, anything that has iodine in it competes with our radioactive iodine, so it makes it look falsely low. And in fact, one of the things that was interesting, and if you read through that chapter, there's a speculation that by utilizing iodinated contrast, that we actually stimulate hyperthyroidism. Did you guys all read that? You better nod your head yes.
That's Joe Basow too, right?
Yeah. If you expose a person to large quantities of iodine, you can actually cause the thyroid to become hyperthyroid. Yeah, but you all know that because you all read the chapter. Yeah. But these are the things here that have a lot of iodine in them too that can also make our uptake very low for the patient. So the Lugol solution, a lot of times we use that to protect the thyroid, to prevent damage to it. The topical iodine, I don't really know, I don't think iodine gets absorbed through the skin, but it's mentioned as one of the things to avoid. Kelp, so if you're one of these people that do a lot of, seafood type stuff, the vitamins and minerals, and so all of these are good examples of things that you want your patient to stay away from. And probably the biggest one is the radiographic contrast agents. Oops. Yeah, remember that 150 micrograms of iodine is all you need per day, and unfortunately these contrast agents here that we give the patient have like 320 milligrams per cc, and we give 50 cc's. So that's a lot of iodine that person's going to be flushing out of their system for a long time. I think most places now wait about 4 to 5 weeks before they'll try to do a scan. What do you guys normally do at your hospitals?
2 weeks.
6 weeks? What do you guys do up in Fresno? Ashley, what do you guys do? How long?
What was the question?
The question is, how long do you wait after contrast before you
2
schedule?
months.
Months?
2 months.
Damn.
Long time.
Yeah, it will, but I mean, the thing is, if you consider that you're giving hundreds of thousands of times the iodine that you need, it's really, okay. And then the same thing with thyroid medications. Mr. Singh, how long do you guys hold off your thyroid medications?
I don't know if I have done it before.
Don't they switch them to like Cytomel if they're on Synthroid,
Yeah.
and they can quit for like 2 weeks?
Okay, well, yeah, thyroid cancer patients or hypothyroid patients, if they're bringing them back, normally they're going to be on T4, or they may have this stuff down here, the euthyroid or Thyrolar, which has both in it. But they normally will switch them to Cytomel, and that prevents the patient from having the withdrawal symptoms. So going from T4 to T3 for 3 weeks, they do that, and then they stop the T3 for a week. Usually for 7 days is more than enough. And then you get the rebound effect. You guys don't do that? Doesn't sound like what you...
I think that's what they do here. I guess it depends on the doctor, right, what they want them to do.
Yeah. Well, and then sometimes too they may augment the thyroid uptake with thyrogen. So you guys may be doing thyroid stimulation with augmented TSH.